Medurstand-Understanding Medicine.
Hi, Professor Aziz-ur-Rehman here. Today we are going to talk about another liver-related disorder called non-alcoholic fatty liver disease, abbreviated as NAFLD. And this is a relatively benign condition. NAFLD as such is just little extra fat in the liver with no significant associated mortality or morbidity. But this has got many associations, and this can progress to a more serious condition called non-alcoholic steatohepatitis, and this is actually a potentially serious condition which is associated with high risk of progressing to fibrosis and cirrhosis, and also high risk of hepatocellular carcinoma. And this NASH may also be associated with many comorbid conditions. NAFLD can also be associated with metabolic syndrome. Now, this is actually a whole broad spectrum of disorders. On one extreme, just little bit of extra fat detected in the liver on routine investigation with no symptoms. On the other extreme, patient is on the verge of cirrhosis. Now, we have to actually decide where patient stands. So we should try to reverse the disease process, or at least try to stop it there so that it doesn't progress to the next stage. And the second thing is that these two conditions are the diagnosis of exclusion. If somebody takes a very significant amount of alcohol, then we call them alcoholic fatty liver disease or alcoholic steatohepatitis. So only if somebody does not drink alcohol or does not drink alcohol in the quantity that is usually associated with these disorders, only then we call NAFLD. I think NAFLD and NASH, they are much more commoner than alcohol-related liver diseases because there is awareness about alcohol intake, and it is mostly because of NAFLD, the non-alcoholic fatty liver disease. Why it is happening, and I'm going to explain to you in next few slides, but generally I think it is because of our changing lifestyle, because of excess energy intake. Now, before we discuss it further, let me introduce some terminology which is used. Non-alcoholic fatty liver disease is a deposition of fat in the liver, but not due to alcohol, or also not due to any other known disease like hepatitis C and hepatitis B and other drugs. So it is actually required whenever you label somebody as a case of NAFLD, it is required that you rule out all other causes. And it is also called metabolic associated fatty liver disease because actual pathophysiologic mechanism behind this liver disease is abnormal metabolism, energy metabolism, insulin resistance, and food intake and weight gain. All this is associated, so it may also be called MAFLD. And previously it used to be called simple fatty liver. And NASH is the next stage, and there are no very definitive diagnostic criteria other than biopsy, but same person, if progresses to the next stage, typically associated with the raised ALT or AST, we label them as non-alcoholic steatohepatitis. The difference between the two is this is just the deposition of fat, triglyceride, and hepatocytes, but this one is actually necrosis and inflammation and progressing to fibrosis. So pathophysiologically speaking, this is truly a disease. This is just an abnormality like a predisposing factor. Now, to differentiate it from alcoholic fatty liver disease, if somebody takes a lot of alcohol, now there are actually definition how much alcohol is safe. So if somebody takes more than that, only then fatty liver can be attributed to fatty alcohol. Then there is a term, and this is very interesting. Typically, this NAFLD is seen in people who are overweight, those people who are obese. But in some cases, patient may not be obese at all. Patient may just have normal BMI, but there is extra fat in the visceral area and the extra fat in the liver. So we call it lean NAFLD. Whether this is a separate disorder or is it also a variation of the same NAFLD, we don't know. But I think genetic factors, they play a very important role here. We also call it thin obesity. The patient is, if you look at the patient, he or she does not impress you as an obese person, but the waist may be increased. And if you do ultrasound, there may be fat in the liver. So this is the terminology we're going to use. Now let's discuss it further. What is the definition? It is the presence of excessive fat in the liver. Like every tissue, liver also has some quantity of fat, but not that you can see with microscopy or with the ultrasound, frankly, present there. So you can see this is the normal architecture of the liver. You can see nice hepatocytes and sinusoids. So no fat deposition. These are actually spaces. These are not fat deposits. These are sinusoids. Okay, so this is the normal and this is abnormal. So you see these big fat globules. Fat globules, they indicate presence of excessive fat. You can see hepatocyte, but some of the hepatocytes are so much distended with fat globules that you can't really appreciate that they are actually hepatocyte. All you see is a big fat globule. So just so many of them. This is typical fatty liver on biopsy. Now, pathogenesis and the natural history, the genetic factors, they play an important role because we know that fatty liver or NAFLD is seen in some races more than others. Like Hispanic Americans, they have highest risk. Asians also have fairly high risk. So genetics play an important role and it also runs in certain families. Diet is perhaps the most important factor. I think one thing in diet is that over consumption of diet, also some diets in particular, like fructose rich diet, carbohydrate rich diet, fat rich diet, and I think those kind of diets, and if consumed in larger quantity, larger refers to the actually the patient need. A patient has got sedentary lifestyle but consumes a lot of calories, and that means over energy intake, and that extra energy is converted into fat and deposited in the liver, and this extra fat is actually synthesized in the liver. Then lifestyle, particularly the exercise, the fructose intake, this has been particularly, I think, recently implicated in fatty liver disease because, you know, these drinks we consume, these beverages, they contain fructose, and fructose is more likely to lead to de novo fat synthesis in the liver as compared to glucose. Glucose is more likely to be consumed in energy production, and same amount of fructose, if taken, that is more likely to be stored in the form of fat. So recently the consumption of fructose has increased tremendously. That is perhaps maybe related to this increased incidence of fatty liver disease. NAFLD, insulin resistance. Now it is very hard to tell which one is primary. Is insulin resistance primary thing that leads to increased food intake and weight gain, or weight gain is primary and that leads to insulin resistance? But we know that most patients with NAFLD, they have insulin resistance and they have excess body weight. So I think both are responsible. Now these days we are very fond of talking about this gut microbiome, and it is also possible that somehow this our food intake or somehow our gut bacteria, they change and there is dysbiosis. Abnormal type of bacteria are produced in the gut which produces certain hormones, certain metabolites which are absorbed into the circulation, and there may be actually absorption of some bacteria also, and they go to the liver and they alter the metabolism. Now this is definitely a very popular theory these days. So the scientists are working on this one also. So how all these factors interact with each other to produce fatty liver disease, we do not know the details, but some of the details which we know I'm going to show you here. So excess energy intake and genetic factors combine, and they lead to accumulation of fat in hepatocytes. And once it is above a certain threshold, it would cause NAFLD, right? Non-alcoholic fatty liver disease. At this stage, only problem is extra fat in the liver, but no necrosis, no inflammation, and ALT is normal. But this may cause oxidative stress. If this goes on, fat itself is not toxic, but once it accumulates and it changes the local metabolism, and that may cause liver inflammation. And this liver inflammation is called NASH, non-alcoholic steatohepatitis. And this would develop only in approximately 25% of the cases who have NAFLD. So there are people who have very significant NAFLD, but they don't have NASH. There are other people who do not appear to have very significant NAFLD, but they progress to NASH. So what actually determines which patient will go on to have this NASH, we do not know exactly. So there are some oxidative stresses, maybe some emotional stress also. So I think these are the factors. And then some unfortunate people, further 25%, will go on to the development of fibrosis, because fibroblasts, fibroblasts are present everywhere. This is a kind of healing process. Wherever there is inflammation, and the healing process is activated, and healing process involves activation of fibroblasts, because wherever there is healing, there is scar formation, like healing of a wound. So these fibroblasts, they get activated and they cause diffuse fibrosis, which is then ultimately cirrhosis. So this is how the disease process develops. So our aim is to detect at this stage and do something to stop it progressing to this stage, or detect at this stage and stop it progressing to this stage, because this one is relatively benign, this is potentially serious. Now, how does it progress? Now, this is, I think, the translation of the same in another form: positive energy balance and deposition of fat. This causes NAFLD, and this may induce inflammation due to oxidative stress, and this causes NASH, and this stimulates fibrosis, and this leads to CLD. Okay, so we have to stop it somewhere. What are the major complications? Why we are concerned about NAFLD? Number one, if you have somebody with the NAFLD, you can predict that this patient is going to develop diabetes. Patient may be actually already suffering from diabetes or another form of diabetes like pre-diabetes, but those who do not have diabetes or pre-diabetes and have fatty liver disease, they are very likely to develop diabetes, because both have metabolic abnormality. So one reason to treat NAFLD or to prevent further stages is to prevent diabetes. Then there is risk of cirrhosis. Cirrhosis is something which with very high morbidity and mortality. And commonest cause of cirrhosis is hepatitis C and hepatitis B, and the scenario is changing. Hepatitis C has become curable. Hepatitis B is also preventable and curable, treatable at least. So the chances of cirrhosis due to hepatitis B and C is becoming less and less. Alcohol related cirrhosis is also on the decline, because people are becoming aware. And this NAFLD and NASH, they are becoming commoner causes of cirrhosis, and they may be actually the commonest indication for liver transplant in the future. In some occasional patient, there may be liver cancer. This is after cirrhosis, or sometime even without cirrhosis, just NASH may progress to liver cancer. So these are three very good reasons why we should treat these patients with NAFLD. Presentation, how do we diagnose? I think mostly patients are asymptomatic. Mostly patients come for other reason, or we screen them. So how we make a diagnosis or how we pinpoint that there is a possibility of NAFLD? Screening of high risk patient. Somebody with high BMI should be screened, and I'm going to show you the tests. So those tests should be performed, and then if needed further tests should be done. Then incidental diagnosis on ALT. In many conditions we do routine tests, and if somebody is found to have elevated ALT and there is no other cause, then we suspect NAFLD. Now this ALT is typically elevated maybe 1.5 to 3 times. It is not very high. If it is very high, there is sometimes I think the possibility of some other disorder. So typically ALT would be, if upper normal is 40, typically ALT would be somewhere in between 40 and like 200, maybe less. But remember, normal ALT does not rule out NAFLD. It is just one of the criteria. Then incidental diagnosis on CBC. CBC is also a common test. Sometime on CBC we find thrombocytopenia, and we investigate. We don't find another cause, but we find NAFLD. So this is how we diagnose. Incidental diagnosis on ultrasound. Ultrasound is also done for various reasons, and many times patient may not have any symptom related to liver, but on ultrasound NAFLD is detected. So all these are patients who are minimally symptomatic or not symptomatic at all. But then because this fatty liver can cause enlargement of liver, and that may put some stretch on Glissan's capsule, and patient may feel this pain and heaviness on the right, in the right hypochondrium where liver is situated. So that may be a cause. Then low grade fever or feverish feeling. This would be more associated with chronic hepatitis due to hepatitis B or C, but in the absence of those, even NASH can cause this low grade fever type of feeling, or at least feverish feeling. So these are the various ways of presentation. No dramatic presentation, right? So you need to keep a high index of suspicion in those patients who are prone to develop it. Typically person who is overweight, and especially if the excess weight is around the waist. Now, these are some of the ways of making a diagnosis. We do some laboratory tests and we do imaging tests, and typically diagnosis is based on both, because one single test is usually not sufficient. So ALT is elevated, as I already told you, more than upper normal, but maybe 2 to 3 times elevated, and in the absence of another cause. CBC, there may be thrombocytopenia. Lipid profile, mostly these patients, they have associated dyslipidemia. Now which one is the cause and which one is the effect, or both are associations with no cause and effect relationship, but many patients with this NAFLD, they have abnormal lipids. Typically their triglycerides are high, their VLDL is high, their HDL is low. These are actually also the features of metabolic syndrome. And then this protein K8 and K18, I'm not exactly sure what they mean, but there are some cytoskeleton proteins. They come from the fibrotic tissue arising from the liver, so they can be detected in the plasma. APRI is a good simple tool. APRI is actually AST platelet ratio index, and I'm going to explain in some more detail in the next slide. This is a simple tool. You can pick up somebody who has progressed from NAFLD to NASH or cirrhosis. And similarly, FIB4 score, I think in the next slide I'm going to show you. The HbSAg and anti-HCV and other causes of chronic liver disease have to be ruled out. As I told you in the beginning, this diagnosis is the diagnosis of exclusion. So you have to rule out coincidental or the hepatitis B or C disease, because they may actually be cause of fatty liver. Both can coexist also. So then I think the diagnosis will be particularly difficult. Then liver biopsy. Now liver biopsy is, although we know it is a safe procedure, but somebody who just have this NAFLD, which is relatively benign condition, So doing a test which is invasive, which has at least some morbidity, mortality related with the procedure, and cost is involved. So we don't do liver biopsy in every patient. It is done only in those patients where it is considered essential. I think somebody who does not fulfill the criteria on these and there is a high suspicion, I think liver biopsy may be done or may be done in trials. And on the imaging side, the most commonly performed test is ultrasonography, and it is great tool to diagnose or to rule out fatty liver disease. I'm going to show you in the next slide. So then there is a shear wave elastography, the fibroscan. This measure the stiffness, and this would actually reflect the presence of fibrosis. So this is one step ahead of ultrasound. Ultrasound is just imaging test. There are some finding which we can see on the ultrasonography, but most patients with fatty liver disease here, they should also have this fibroscan to determine if there is fibrosis. Now, ultrasound actually is not very good at detecting fibrosis. It can detect fatty liver, it can detect size of liver, it can detect cirrhotic changes, but as such fibrosis the ultrasound cannot pick up very effectively. The shear wave elastography gives us better picture. Now I'm going to talk about these two in the next slide. What is APRI? It is AST to platelet ratio index. Now what is the philosophy? We know elevation in AST is a criteria for NAFLD and NASH, and a reduction in platelet count is also a sign. So if we combine both in one formula, that's become more sensitive. So APRI is actually AST of the individual divided by AST, which is upper normal, in normal range. So you will take patient value and you will divide it with the upper normal AST, the same kit, and divided by platelet count, which is taken in this figure like 200, 250. Normal would be 350 or 450, 250 to 450 like, and then we multiply it with 100. So this will give you a APRI index. It may be 1, it may be 1.5, and higher the index, it has got more positive predictive value that patient has fibrosis and cirrhosis. And if the value is very low, like 0.5, it has got very high negative predictive value that patient does not have cirrhosis. Now, in between these two extremes, you have various numbers. Of course, one score does not give you the final diagnosis, but definitely gives you some idea where on the spectrum patient stand. A low APRI score would indicate that patient is at a very low risk of developing cirrhosis, and a high APRI score would indicate that patient is at a high risk of developing cirrhosis or has already developed cirrhosis. This is FEB4, and this is actually slightly different. You add age in this formula. The formula is different, and this is a little more complex. There is app available, and you can have these formulae from the app, and these are calculators available on the net, free of them. Again, you use the 4 variables and you find out where in the spectrum patient stands, high index, high suspicion, or very low suspicion. So these are some of the things you can do. Ultrasonography, and these are the images, and this is normal. This one is also normal. Now those who are experienced, they know what is the texture, the echo texture of liver. This is liver, and this is diaphragm, and this is kidney. Now you can see the contrast between kidney and liver, this here also. But as it progresses, then you lose that contrast. You see, this kidney is hardly visible here. Liver has become more echogenic, and the contrast between liver and kidney is lost. And here you can appreciate the diaphragm very well separate from the liver, but here it is like almost similar to liver. So this is how they tell, but of course ultrasonologists will tell us if there is presence of fatty liver. There are grades of fatty liver, grade 1, 2, 3. So parenchymal brightness is increased, liver to kidney contrast is loose, there is deep beam attenuation, and there is some abnormality related to brightness of vessel wall. So these are the things which we see on ultrasound. Shear wave elastography. Now this is a technique which may be ultrasound based or maybe MRI based. Now with the transducer, high energy ultrasound waves are emitted. Now, and this is the transducer is put on the liver, on the skin of course, but on the liver, and this will put these shear waves in the liver. Now, depending upon the texture of liver, these shear waves will change, and they are measured in kilopascals. So a specific number is allotted, and if it is below that number, it is considered normal. A normal liver has got very soft architecture, but a fibrotic liver would be hard. So based on this, and of course I do not know the physics behind it, but this would produce a different pattern in the shear wave which can be detected by the instrument. So this we can assign a specific score, F score, which refers to the fatty liver, steatosis, and F score which relates to the fibrosis. F0 would mean no fibrosis at all, and F4 would mean there is full-fledged cirrhosis. F2, F3 and 4 are cirrhosis. F1 and 2 are not cirrhosis. So I think you can refer the case with NAFLD for fibroscan, for elastography. It could be ultrasound based or it could be MRI based. MRI is of course better, but MRI is more expensive and is not available everywhere. And I think mostly we do ultrasound based fibroscan or elastography. So diagnosis ultimately is based on presence of excess fat in the liver, which is determined on ultrasonography, and absence of chronic hepatitis C, chronic hepatitis B, excess alcohol intake, and known drugs. There are certain drugs which can cause fatty liver, and they should be ruled out. So this is how we make a diagnosis, and there are some associated conditions. Why? Because as physician, we are looking after the patient as a whole. We're not just looking at the liver. Maybe hepatologists will be concerned only about liver, but we physician internist, we are concerned about the whole patient. And I think anybody who is found to have fatty liver should be screened for associated metabolic condition, because they would need attention also. They need intervention. So diabetes or pre-diabetes. Many of these patients would be diabetic or pre-diabetic, and appropriate step may be taken. Now, if you treat diabetes, there are some agents which may be particularly helpful for liver disease also. I'm going to talk about this later. And in truncal obesity, waist circumference, people, male patient may have, normally they should have their waist measured at the level of umbilicus less than 40 centimeter, and in female it should be less than 30 centimeter. But different societies, they use different criteria. Some have tighter criteria, like they would say male should have less than 35 and women should have less than 28, like that also. Blood pressure, patient with metabolic syndrome, they have high pressure or slightly elevated or frank hypertension. Dyslipidemia, I've already briefly talked about it. Patients are likely to have high triglyceride, high VLD, and may have low HDL. So these are the associated conditions. Some benign associated conditions like acanthosis nigricans or tag formation, and these are also present in these patients. What is the treatment? After the diagnosis, we have to treat. I think before we discuss treatment, one fundamental question: is it reversible? I think only theoretically. In real life, frankly, I have never seen somebody who had known fatty liver or NASH, with intervention, he has gone back to normal liver structure. It may happen very rarely in real life, But theoretically, I think if we can reverse what actually caused NAFLD and NASH, if we can reverse that, theoretically it should be reversible. So first of all, we should try negative calorie balance. Patient should reduce food intake. All kinds of food should be reduced, and patient must add some exercise, any kind of exercise, and as a net result, patient should lose weight. So 10% or 15%, 10 to 15% of body weight, if lost and maintained at that level, I think that may lead to regression of NAFLD, or at least it should stop further progression to NASH and cirrhosis. Hepatoprotective drugs, there are many herbal drugs which are claimed to be effective, and silymarin is one of them. Although there is evidence, at least theoretical basis for silymarin to be effective, it has got antioxidant, anti-inflammatory, anti-fibrotic, anti-apoptotic effect, and they can be used in NAFLD, and they are used. We know something that at least it is safe because it is herbal and it is safe, so it is used with some theoretical evidence that it would be effective, and it is used in some other conditions also. The natural occurring silymarin is not very bioavailable, and we have many preparation which give us a different formulation which is better absorbed or which is more potent. The actual active ingredient in silymarin is silibin. So that is, I think, available in the pharmacological form these days. Vitamin E is also antioxidant, and this may also be used. Typically, we use these two together. And pioglitazone is an anti-diabetic drug, and if somebody is diabetic and has also fatty liver, pioglitazone may be included in the treatment regimen. Although pioglitazone has a downside also, it could lead to weight gain. So we don't want weight gain. So weight gain is also associated with NAFLD. So I think you have to balance the associated risk and the benefits. Pioglitazone in moderate dose can be given. GLP-1 receptor agonists, these are great anti-diabetic drugs. They can also lead to regression of NAFLD. And statins, many patients with diabetes, they have associated dyslipidemia. So statins can also theoretically, to some extent, regress this NAFLD. So these medicines should be included along with the other treatment regimen. There are some experimental medicine, and I'm not going to talk about them till they are available. And then metabolic surgery. We know that this bariatric surgery, sleeve gastrectomy or Roux-en-Y operation or any other kind of metabolic surgery, is very effective to reduce weight and to control associated problems. Many patients, they can manage their diabetes without anti-diabetic agents, and their blood pressure may be controlled without antihypertensive. Their dyslipidemia may be controlled without statin. So metabolic surgery is great. But in which patient you would like to do metabolic surgery is hard to define. Somebody who does not have cirrhosis perhaps would not be keen to have the surgery, and somebody who has already developed cirrhosis and that person may not be very fit for the metabolic surgery. So where to perform this surgery is hard to decide. I think it would depend on individual cases and individual physician, but this definitely can stop the process from further progression. Liver transplant, of course, this is not a preventive treatment. Those unfortunate people who go on to develop chronic liver disease and cirrhosis and ascites, decompensation, they can have liver transplant. And currently it is number 2 indication after chronic hepatitis C and B, but it is predicted that since hepatitis B and C are coming down, in future the commonest indication of liver transplant would be cirrhosis due to NASH and NAFLD. So that tells us how big this problem is. So we need to work to stop the epidemic of this disease, which is everywhere. So we should start working even if you do not have NASH. I think if you have NAFLD, you should start working now. And the best thing you can do about yourself is to go into negative calorie balance. With that, I'd like to thank you, and I hope this video was also useful for you. And please join me in my next video, which is going to be on some other disorder. Thank you.